It is morning here
Mhm.
and a very cold day. We had a snowstorm last night, and you can possibly see some snow outside the window. I would like to thank the organizing committee for inviting me. It's a great pleasure to join you. The topic that I've been assigned today is thyroid cancer alternatives to surgery. Our objectives today are as follows. I'll discuss a case-based approach to differentiated thyroid cancer. We will be tackling topics of lobectomy versus total thyroidectomy, and where would you go with each of those options. We will talk about the new concept of active surveillance, also new and upcoming non-surgical techniques for ablating thyroid cancer, and we'll briefly touch on the topic of TSH suppression. I'm going to present to you two of my cases. Case one is a 32-year-old female who presented to us with a 1.2 centimeter thyroid nodule. She had a fine needle aspiration biopsy, which showed papillary thyroid cancer. She's otherwise healthy. The question is, how should we approach this case? And the second case is a 67-year-old female, and she presented with a larger 3.2 centimeter nodule. Again, fine needle aspiration biopsy was suggestive of papillary thyroid cancer. She has a history of high blood pressure, underactive thyroid, bone problems, and glaucoma. And how would you approach this case? Now, it shouldn't come as a big surprise to anyone in the audience that thyroid cancer is exceedingly common. And unfortunately, both the incidence and the prevalence rates of thyroid cancer are rising quite rapidly. And it is mostly due to sophisticated techniques, the imaging techniques, widespread use of ultrasound, CT scanners, and that's why we are picking more and more of these cancers. If you were to look at these data, and these data came out of the US, and this is epidemiology trends over well over a decade, you will see in this particular slide that there has been a significant rise in all stages of thyroid cancer except stage 4, which is the more advanced stage. So essentially what you're seeing is that more early stage cancers are being picked up. And this is a very elegant study which was done in Korea and illustrates the point that I was making earlier. In this particular study, they essentially showed that there was an increase in the age standardized incidence, which is shown here. I don't know if you can see my pointer with this blue line, and there has been a significant increase in the age standardized incidence. On the other hand, though, there has not been much change in the mortality. So therefore, you have a rising incidence and pretty stable mortality. Therefore, not surprisingly, you have a huge prevalence. But more interestingly, if you were to see on the right side of the slide, then and then what you're seeing here is that over a course of last number of years, well over a decade, most of these cancers were picked up. They were smaller cancers, less than 2 centimeters. Vast majority of them are actually under a centimeter. And again, most of them were picked up through screen detection, i.e., for scan done for another reason, and these cancers were picked up. not necessarily because they presented as cancers. The same trend is happening here in our country, in Canada. And if you were to look at the incidence of thyroid cancer in Canada, this is where we are in Nova Scotia. And over the last few decades, the trend has been gradually upwards. However, it has definitely risen more prominently in young women. So what we do see now is that there has been a significant increase in the incidence of thyroid cancer in young women, shown here by this purple line, and also in men, whereas there hasn't been any change in mortality over the last few decades. So in summary, I hope I've been able to convince you so far that the incidence and prevalence of low risk, because these are typically small cancers, 1 to 2 centimeter, is rising worldwide. And the trend is mostly driven by increased screening and identification of smaller cancers. Mortality hasn't changed. And if this trend continues, which is likely set to continue, then we will have an increasing accumulation of these patients over the years. I'm not going to spend too much time on management, because this is not what the talk is all about, but I'll just quickly give you a breakdown of how we currently manage thyroid cancer. And this won't come to you as a big surprise, because I'm sure most of you deal with it. So the first step is surgery. Now, there are controversies whether we should do partial thyroidectomy or lobectomy or a total thyroidectomy, whether or not lymph node dissection should be done, if so, how much. Then radioactive iodine therapy. When I first started looking at thyroid cancer patients 20 odd years ago, we were using radioactive iodine left, right, and center. Fortunately, we are not using it as frequently. But the question is, who are the patients where radioactive iodine therapy can be used? And then if we do decide to use it, then what dose? And then finally, there are TSH suppression through thyroxine. And again, there's controversy, how long, how much? And now I think there are a number of other treatment options coming up. And there are biologics, there are TKIs and others. And I'm not going to discuss that because that's besides the scope of our talk today. But new medical treatments are coming up. External beam radiation therapy is something that is also used. So there's a whole variety of options. Now let's look very quickly about thyroid surgery. Now, I'm going to present to you two guidelines, one from the US and the other is a European set of guidelines, and they're similar. If I were to just focus primarily on the North American guidelines, the ATA guidelines, they sort of divide it in three categories according to the guidelines. If your primary cancer is more than 4 centimeters and there's evidence of gross extrathyroid extension, then you basically go for a total thyroidectomy. If it is between 1 and 4 centimeters, then you can either go with total or partial thyroidectomy. And again, there are a number of permutations, and it's very subjective. But depending upon your patient, you can choose one or another. And if it is less than 1 centimeter, and if surgery is chosen, and that's, I think I've underscored that because that is an important point, and I'll come to that later on, then a lobectomy would be adequate. So this is very different concept from what previously was suggested by the ATA and other organizations. And what are these data based on? So essentially, if you look at a large number of patients, this is over 22,000 patients from the SEER database, and you look at the 10-year disease-specific, either overall or disease-specific survival. So this is your overall survival or disease-specific survival, and this compares lobectomy versus total thyroidectomy. In this study, these patients did equally well. So there was no significant. In this particular study that was published in 2018, and this is for low risk 1 centimeter patients. And what it showed was that if you treat these patients with total thyroidectomy versus lobectomy, and looking at various studies, the rate of recurrence is very similar, and you get lesser complications. So that's no surprise. And the reason is that neck is a very vital structure with a lot of intricate organs there. And if your surgeon is not well versed with surgery, then the risk of complications and permanent damage is quite significant. Therefore, it is important to minimize surgery or the extent of surgery to minimize the risk of complications. Now, if you were to look at the rate of recurrence, and these are a couple of studies that I have taken to illustrate the point, after lobectomy, and this is again in patients who were not necessarily less than a centimeter, but patients who were carefully chosen, slightly larger tumors, you can see that the rate of recurrence, so not necessarily just complication rate is low, but the rate of recurrence is also quite low despite lobectomy. Therefore, there has been a change. We practice. This study came out of Israel, and essentially what it was that since the new guidelines came out, the rate of completion thyroidectomy, which is removal of the total thyroid after lobectomy, has reduced significantly from where almost two-thirds of the patients were having complete thyroidectomy. Now only 20% of those are undergoing completion thyroidectomy, and a lot of these people are being spared this additional surgery. So I think overall it change. So I think what so far I have illustrated is that there has been an increasing trend toward less aggressive surgery. And despite that, so far we haven't seen a marked increase in recurrence, and certainly there has been a low rate of complications. What can matter? So what about just observing these patients without surgery? That's one option. What about non-surgical ablative techniques, medical therapy, and TSS suppression therapy? I'm going to focus on, I'm not going to talk about medical therapy. I'm going to talk a little bit about TSS suppression therapy and observation without surgery and non-surgical ablation. No, observe without surgery. This, again, is a slide that I took from the ATA guidelines. And essentially what it says is that if you come across a thyroid nodule, and the nodule is actually small, it is approximately a centimeter or so, you can continue to, if it has high suspicion pattern and all the rest of it, you can just continue to monitor this. So basically, there are now several centers have looked at it, several studies have been published. I'm going to just take a couple of these as representative studies. So this study actually initially came out of Japan, where they compared the outcome of over 1,000 micropapillary carcinomas. These are less than a centimeter, who underwent surgery, And they had around 340 patients who they decided just to observe, and they followed them for a mean of 74 months. So essentially what they showed was that around 5 years later, the rate of enlargement of the tumor in those 340 patients who were undergoing observation was actually very low. And the risk of nodal metastasis was also very low. And even at 10 years, most of these patients, they are still doing fine. There has not been, these are documented thyroid cancers, there hasn't been a significant change in the primary cancer, and somehow or the other, their immune system is keeping it under check. What they then did, there are two hospitals. One is the Kuma Hospital, and the other is the Tokyo Cancer Institute. And they followed a number of patients, over 1,200 at the Kuma Hospital, 230 at the Tokyo Cancer Institute. They would scan them through ultrasound every 6 months, and surgery was conducted if there was more than 3 millimeter enlargement or there was evidence of lymph node mets. And essentially what they showed that in both cohorts, either Kuma or the Tokyo Cancer Institute, the overall risk of tumor enlargement was very low, and this is a 10-year follow-up. 7 to 8% of these patients showed an increase in the size of the tumor. Now, this increase of more than 3 millimeters has been called into question, and I'm not going to go into that. But the point is that vast majority of these patients did very well and continue to do well, and they do not require any intervention. As a result, now the concept of active surveillance has come into being, and now what we are suggesting that, I'm sorry, it's a busy slide, but essentially what it shows is that if you have a patient who is older and who accepts the active surveillance and will continue to monitor, and where you have a you have a low risk thyroid cancer, and you can find these things on the ultrasound, you can continue to monitor these patients without actually operating on them or without removing the tumor. Whereas if you have a younger patient, you have concerns about compliance, or there are ultrasound features which are shown in this particular slide, then you have to proceed with surgery. So most of these data come from studies that have looked at tumors that are less than a centimeter. We really don't have any studies looking at larger tumors because most of these tumors, which are low risk tumors, are found incidentally are between up to 2 centimeters. So we are actually currently doing a study in Canada. I'm part of that, and this is a prospective long-term study looking at this particular question. Hopefully in the next few years we'll be able to give you an answer. What about non-surgical ablation technique? Well, there are three. There is laser ablation, there's radiofrequency ablation, and there's percutaneous ethanol injection. And different centers use different techniques. The radiofrequency ablation, this is a study out of Korea. They've done very well. Essentially, what they did in this particular paper, they treated 155 patients, and they were microcarcinoma, i.e. less than a centimeter, between 3 to 10 millimeter. Over a number of years, they followed them, and they found that in about 91% of the patients, the tumor after treatment disappeared over a number of years, and the rate of complication was actually very low. So excellent alternative if you choose to do something, other than active surveillance. If you decide that you want to do something, then rather than operating and removing half of their thyroid, you could potentially use radiofrequency ablation. Laser ablation has been used by some centers. I'm just going to show you this particular study where they treated a patient who had 8 millimeter papillary thyroid cancer with laser ablation, and this patient did very well. This study looking at ethanol injection came out very recently, and came out of the Mayo Clinic, where treated over 7 years, about 15 patients, again, low risk cancer. They followed them over a course of 64 months. And essentially what they showed that there was a 93% shrinkage in those thyroid cancers, and these patients seem to have done well. So regardless of technique, which technique you use, these are results. This is a systematic review, a pooled analysis of ethanol injection technique versus reoperation for locally recurrent. So this is recurrent thyroid cancer. Sorry, it's a busy slide, but essentially it showed that the compared to the recurrence rate in both after either technique are very similar. So in essence, it doesn't matter which technique you want to use, whether it is in the injection technique, whether it is the radio frequency ablation. Not quite as much experience with laser, but I think whatever you are comfortable with, your patients will generally do fine. I'm going to briefly touch upon the role of TSH suppression therapy. Now, TSH suppression therapy is important because your thyroid cancer is driven by TSH. So if you have a high-risk cancer and your TSH is high, so that will lead to stimulation of thyroid cancer cells. So we suppress TSH to reduce the risk of recurrence. What about patients where you have not operated, you have not removed their thyroid cancer? Can you use suppression in these patients? I think we all know, and there are plenty of data out there showing that in patients who have thyroid cancer, in those patients, there's no question that TSH suppression therapy is useful in select patients. But in those patients who have not had surgery or in active surveillance type of situation, is there any evidence? And the answer is really not much. We are looking at this particular question in our study, but what I can tell you is that in that Japanese study, what they found that of the cohort, 51 patients were on TSH suppression therapy, and of those, 2% progressed, whereas in the rest of the patients who were not on TSH suppression therapy, almost 5% progressed. So there is a hint that it might be useful, but I think proper studies need to be done, and we are currently in the process of trying to it. So going back to the initial cases, so we talked about these two cases. Case one was a 32-year-old female with 1.2 centimeter thyroid nodule. Case two was a 67-year-old female with a 3.2 centimeter nodule. Both had thyroid cancer. So how would we deal with these two situations? So, you know, we kind of had a deeper look into their ultrasounds. So in case one, this was solitary nodule and I've ticked those boxes here. You can hopefully see the tick marks. So solitary nodule, well-defined margins, and there was normal thyroid parenchyma around that nodule. There was no evidence of extrathyroid extension. No nodal mets were seen on the ultrasound, and the cytology showed no high-risk features. Now, while this patient may not be, typically we like to follow these patients through active surveillance if they're older. But if you actually look at this area in the middle column, if you are 18 to 59, where this patient is and has all the good features, then this patient would be fine for active surveillance, and you could just continue to monitor this patient without offering them. In case 2, if you used case 2 and had the exact same features, then yes, you can also continue to monitor these patients without doing any operation. So at the end, the take-home points are that most differentiated thyroid cancers, specifically less than a centimeter, maybe even less than 2 centimeters, we don't know, but we are looking at it, they may not require immediate surgical treatment. And they can be followed through active surveillance, and that's a very reasonable option in a number of these patients. For those who do not feel comfortable with active surveillance and they want something to be done, you can offer them non-surgical options such as laser treatment, radiofrequency ablation, or ethanol injection. Whether TSS suppression would be useful, still, I think jury's out, so we'll continue to look at it. However, there are problems, obviously, with this approach, and obviously there are problems with anything. And the problem in this case is that people who require active surveillance, they do need more intensive follow-up with ultrasounds, imaging studies. And that is a problem because there is such a huge number of these patients that our clinic rooms are filling up with these. So it's hard to discharge these patients back to their primary care practitioners. And this will increase the workload for endocrinology, while it will reduce the workload for surgeons, but increase the workload for endocrinology. And I think that we need more studies to kind of better define which group we should treat with which particular type of strategy. So thank you once again. I wish you all the best and stay safe.